Welcome, everyone, and thank you for joining the 6th Annual Headache and Migraine Policy Forum, Capitol Hill Policy Forum, held in conjunction with Headache on the Hill, sponsored by the Alliance for Headache Disorders Advocacy. I'm Lindsay Vidinieks, and I have the honor of serving as Executive Director of HMPF, a stakeholder coalition of nearly 24 patient and clinician advocate organizations in the migraine and headache disorder community. In previous years, we have focused this forum on issues related to veteran and first responder toxic exposures, the nationwide shortage of headache doctors, disabilities, and comorbid conditions. This year's topic focuses on addressing inequities in Native communities and couldn't be more important. To get us started, I wanted to acknowledge that before and after this session, just over 200 courageous advocates will be Zoom meeting with half of all members of Congress to raise awareness about headache disorders and to ask for federal support for research funding and other initiatives. We are so thankful for your advocacy. You are representing millions of people nationwide, and we thank you. And we invite everyone joining today to follow the conversation on Twitter using the hashtag HOH2022, which is in the upper left-hand corner of the screen. To kick things off, we're pleased to feature remarks from two esteemed congressional speakers, Congresswoman Teresa Leger-Fernandez of New Mexico and Congressman Don Young of Alaska, who has provided recorded remarks. Our first speaker is Congresswoman Teresa Leger-Fernandez, who represents New Mexico's 3rd Congressional District. She holds a leadership role with the Congressional Hispanic Caucus as freshman representative and serves as chair of the Subcommittee for Indigenous Peoples of the United States for the 117th Congress. She has also been appointed to the House Committee on Education and Labor, the House Committee on Natural Resources, and the Committee on House Administration. She is a 17th generation Northern New Mexican, and before coming to Congress, Leger-Fernandez worked as an attorney and advocate and won important legal battles to advance voting rights, promote tribal sovereignty, and protect our environment in the Sakia waters. She has helped secure nearly $1 billion for and then helped build schools, rural health clinics, broadband, businesses, affordable housing, and critical infrastructure for New Mexico. Please join me in welcoming Congresswoman Fernandez. Congressman, thank you for being here today.
Good morning, Lindsay, and thank you for the introduction. I do really appreciate the Headache on the Hill title of today's event. I really am grateful for the invitation by the Headache and Migraine Policy Forum and the Alliance for Headache Disorders Advocacy to have me here, because I think it's really important that we begin looking at all the different health needs and issues affecting our communities, and in this instance, with a focus on our Native American communities. So as you noted, I represent the beautiful and beautifully diverse 3rd Congressional District. In my district, I have 16 Native American Pueblos, the Jicarilla Apache Nation, and large portions of the Navajo Nation. And as you noted, as chair, and then in the 30 years, I'm a brand new member of Congress. And the 30 years before that, I did all of this work with Native Americans, helped them build health clinics that were very much focused on culturally really relevant healthcare, like what they needed, because we know that Native American tribes, when they can run their own health clinics, when they can tell us what they need most, those health clinics are incredibly successful. We also, I think, in a very important moment right now, where the federal government is finally, I think, fully acknowledging the trust responsibility that it owes to tribes and acknowledging how we have failed in that trust responsibility over the decades and over the centuries. And now we are at this point where we're saying, not anymore, right? Not anymore. We have seen through the devastation of the pandemic how our failure to live up to that trust responsibility has meant death and despair in our tribal communities because they were not equipped. And we are in this point now where we have to say, well, we must listen And as we listen to what are the unique needs, on all areas of that trust responsibility, what do we need to do? And health is incredibly high among them. And we also now know that the issues of migraines and headaches is tribes are sadly overrepresented in that issue as well. We tend to see that tribes get overrepresented on the bad indices and not on the good indices. So while we know that 1 in 10 Americans might experience headache disorders, in Native American communities, we see that there's a higher prevalence of migraine or severe headaches. And then you combine that, increased pain from this affliction with the fact that there isn't as easy access to the care needed to address migraine and severe headaches. We had in the Build Back Better bill significant funding to increase and to fix a long, long list. We call it our priority list, but it hasn't been updated since the 90s because the list is so long, we haven't been able to fix it. So we have this combination of great need and not enough resources. Last month, I visited the Gallup Indian Medical Center and saw how thinly spread our responders were. So, we need to get more healthcare because our responders, our healthcare workers are tired. There's only one Indian Health Service neurologist for 125,000 people receiving care in the Phoenix area and Navajo service areas, Navajo being one of our largest tribes, the largest tribe. And we're still only one doctor across the IHS totally specializes in headache medicine. So these disparities show a clear need for Congress and the IHS to bolster its investments in healthcare for Native Americans. And that means we got to target more resources, specifically for research into headaches and migraines. Why are they higher for Native Americans than for other communities? What can we do better in treating those who are suffering from headache disorders? And so I'm committed to working with you all here today. I'm looking for you to send me suggestions and ideas and programs. That's why I sit here in Congress and as chair is to receive from you, from the experts on the ground who are experiences this, the specific issues. If you see, it's not just a resource issue, but it's also do you want to create some policies? Do we want to create some programs, some pilot programs? Let us know, and let's see if we can get that into legislation, into appropriations and done. So thank you so very much for having me today.
Thank you so much, Congressman Fernandez, for your leadership, but also the fact that you're solutions oriented. We know that you'll be meeting with one of your constituents who's taking part in Headache on the Hill later this afternoon. And so we're so excited that you are helping work to solve some of these problems. So we appreciate you. We're also grateful to have remarks from Congressman Don Young of Alaska, who currently serves as the most senior Republican on both the House Transportation Infrastructure Committee and the House Natural Resources Committee. He has brief remarks, but I do want to provide some of his bio for background because it's quite remarkable. He calls Fort Yukon, Alaska home. That's a remote village of approximately 700 people located 7 miles above the Arctic Circle in Alaska's central interior region. And between earning his associate and bachelor's degrees, he served in the U.S. Army's 41st Tank Battalion from 1955 to 1957. When Congressman Young first moved to Alaska, he made a living in construction and tried his hand at commercial fishing, trapping, and in the search for gold. In Fort Yukon, he taught in a 25-student 5th grade elementary class in the Bureau of Indian Affairs School. Constructed of logs, the school had a wood stove that kept his Alaska Native students warm in the sub-freezing Arctic winter. And with the annual spring breakup of the river ice, Congressman Young captained his own tug and barge operation to deliver products and supplies to villages along the Yukon River. Even today, he remains the only licensed mariner in Congress. He proudly serves as the congressman for all Alaska and loves his role as the only Alaskan representative in Congress. So we are honored that he has provided remarks for our forum and a special note for his constituent, Michelle Cromer, who's joining Headache on the Hill today.
Hello, this is Congressman Don Young. I want to thank the Headache and Migraine Policy Forum for inviting me to speak to you today on crucial subjects, a topic we all are aware of. It's called the migraine headache. I especially want to thank Michelle Cromer of Sterling, Alaska, for her leadership with the Alaska Native communities, and globally this is the big issue. Migraine disease is the #2 leading cause of disability, and too often Alaska Native and American Indian communities are underserved with this seeking treatment. It is an issue that I have to serve with a lot. I don't have migraine headache, and I've been here, and one of the biggest problems you don't understand that this does affect a lot of our people in Alaska. It's sort of in the background. I would suggest wrestling my best friend. I had migraines to a point where we'd go hunting, and I'd have to be very careful. Did he get one? And I'd have to bring him back to my place to make sure he was taken care of. So it is an issue that we have to address. We're doing this. It is a big issue. And Michelle, thank you for your effort. I'll continue to work with you. You're going to meet with my staff. There's no IHS doctors, that specialize in headaches. There's a lot of different suggested ideas, but there has to be done more research so we can address this issue. It affects a lot of Alaskans in different ways, but across the globe, it is probably the #1 thing. What causes, how do we treat, and can we prevent? That's our biggest goal. And thank you, Michelle, for working on this. I'll continue to support you as you meet with us because I want to solve this problem.
We are so grateful for the leadership of both Congressman Fernandez and Congressman Young, and we appreciate their participation. You heard Congressman Young talk about his friend. Nearly everyone knows someone who lives with this disease. And so their comments truly underscore the why of today and our need to recognize the inordinate burden on American Indian and Alaskan Natives living with migraine and headache disorders, and importantly, what we can do about it. So all of this only increases disparities. We know in 2022, these communities still experience worse health outcomes compared with the US population, high rates of poverty, high unemployment rates, barriers to accessing higher education, poor housing, lack of transportation, and geographic isolation all contribute to structural inequities. And this community has also been hit hardest by COVID-19. And so with that in mind, we are looking today to talk about these issues and also solutions for increasing access to care and providing the full range of medications, services that can help prevent or reduce complications of chronic diseases like migraine. We have a respected panel of experts today who are going to explore this. And then later, we're going to hear from Dr. Robert Shapiro, founder of the Alliance for Headache Disorders Advocacy, about these potential solutions that the federal government might consider to help address disparities in this most underserved patient population. So first, let me introduce my panel. We have Dr. Mike Stitzer, who is a board-certified neurologist who has served Native communities at the Winslow Indian Healthcare Center since 2012. He is also an enrolled member of the Enterprise Rancheria Estamimeka Maidu tribe. And we also have with us Mr. Aaron Yazzie, who's president of the Tachi Blue Gap Navajo chapter and is a person living with migraine disease. He is also Dr. Stitzer's patient. And then last but not least, Dr. Blair Matheson, who is medical director for National Medical Services, which provides physician and nurse practitioner staffing and primarily serves Native American populations. Dr. Matheson also serves as board member of the Association of American Indian Physicians, which his father helped found in 1971. He is a member of the Cherokee Nation. Thank you all for joining. We are honored to have some wonderful panelists to discuss this issue, one that does not receive nearly enough attention as a disparity among disparities. So Dr. Stitzer, I'd like to start with you. We heard the congressman talk a little bit about the disparities and what I call fast facts about the lack of resources and providers in this space. Can you just talk about very broadly what this means for the community from your experience?
Yeah, thank you. Again, first off, thank you for having me today. This is definitely a very important topic, and so we appreciate your focus. As far as I can speak to my experiences working with the Navajo area at tribally run sites. And as one of the few specialists, when I first came out here in 2012, I was the only full-time neurologist for Navajo area. And so I would see, all of the patients that would get care here that needed neurologic consultation. That was about 240,000 people. I would also see people from Albuquerque and Phoenix areas. That was an additional about 300,000 people. There was one other full-time neurologist who's still here in the Phoenix area, Dr. Carolyn Badir. But so when I first came out here, there was certainly a large gap in care. There were a few neurologists that would come from the University of Arizona, and that was excellent. They would provide service every so often, a few times per year, and that was needed. But ultimately, it was just a few times per year, and so there would be quite a delay in the patients being able to get the care that they needed. Wait times to get in with the neurologist would be months and months. And so coming out here and being able to be a full-time neurologist at tribally run sites allowed me to be able to provide that general neurology care. And one of the things that clearly was a large need and still is all the patients that have migraine headaches and other kinds of severe headache syndromes.
I think that that's a narrative we hear often, but you're on the ground and experiencing it. I always want to make sure that the conversation we're having is patient-centered. And so shifting from, the data and the provider experience, Mr. Yazzie, as Dr. Stitzer's patient, as someone in the Native community, can you talk a bit about your personal experience, how hard it's been to navigate both diagnosis and treatment of your disease, and sort of the challenges you've seen from the patient side? Oh, I think you might be on mute.
Well, good morning. I believe it's still morning. I don't know about the East Coast, but we're still in the morning stages on this side. Yes, I would like to just comment on a lot of issues that we are experiencing here on the reservation. And as I said earlier, we are in remote areas where a large, vast, the reservation is remote. So in order for us to go see physicians and go to hospitals, we have to travel about 30 miles, sometimes more than that. And when we get there, it's either the doctor just prescribes a medication to temporarily, just kind of like a Band-Aid. And the diagnosis comes only when the patient is very persistent in getting care. So when that happens, then there are no specialists. So then the doctor has to refer the patient out to our outside resources, such as Dr. Stitzer. He was one of my referrals that I was referred to, and it took about at least 3 months before I would be able to see him. So so that's kind of how hard it is to find medical help. So it takes a while for the diagnosis to take place because of the lack of doctors or the change of doctors. And what I mean by that is you would see a doctor for a few months, and then when you return, then that doctor has moved on. So you have a new doctor coming in. So you kind of have to start all over again. So that's kind of the situation with IHS. And sometimes I guess there would be a misdiagnosis of what your issues are, and certain medications are given to you. But then again, you go back the next time, they do another evaluation, then it becomes a different issue. So and that's kind of how it works. And in my case, I was involved in an accident, a head-on car accident with a drunk driver, and I experienced some trauma during that time. So that's when it sparked my headaches, and that's how I was able to go see doctors and go into IHS to get a referral, and that's how I get to know Mr. Stitzer. So, so that's kind of how it is on the reservation. It's very hard. All these resources are not immediately available. So especially I guess in the migraine area, all of the referrals that are done are either outside the reservation, and none of it is taken care of within the community, because the community hospital. So even with children, they have issues. Um, they have to be referred out to Children's Hospital in Phoenix in order to get treatment. So a lot of those issues are still remaining here, and it would be helpful to talk about how we can get the services into the reservations to get adequate services for the people of the nation. So I'm glad that I'm a part of this conversation, and I hope that that what we're talking about would be able to move forward with this, and it would be something that we can do. Even the veterans about the same thing. We veterans, we have to be referred out to Prescott, to a veteran hospital. So a lot of these things are just initiated by IHS, but then again, it's referred out to the specialists outside. So that's pretty much my comment on that.
Thank you so much, Mr. Yazzie. And that's probably a good sort of segue to asking Dr. Stitzer about, for a lot of us who don't know about the structure of IHS, how it is, how it's trying to fulfill its mission. Can you describe, sort of give us an overview of how that works in terms of on an organization level, if you could?
Sure. Yeah. So I'll start with kind of the very broad overview of, Indian Health Service is an agency within the Department of Health and Human Services. It was created in 1955 off of the basis of Article 1, Section 8 in the Constitution, some case laws between the government, the federal government, and tribes, and various treaties. The current mission of IHS is to raise the physical, mental, and social and spiritual health of American Indians and Alaska Natives to the highest level. And we're doing that in a variety of ways. So as of 2020, IHS provided healthcare to about half of the nation's 5.2 million American Indians and Alaska Natives, who are members of 574 federally recognized tribes. And the way that IHS does that is through breaking up into 12 service areas based on kind of geography and the amount of people needing healthcare in each of those areas. And then further divides each of those service areas into 170 service units that spans 37 states. And so those service units are a combination of federally funded sites, tribally funded sites, and both of those are typically in rural areas, either within tribal lands or nearby. And then there's also grants and contracts provided to a variety of urban Indian centers. And so overall, between all of those things, there's 46 Indian hospitals across the country, about 1/3 of which are tribally operated, and 630 Indian health centers, clinics, and health stations. And about 80% of those are tribally operated. And so, for example, again, where I've been working within Navajo area has been at Tuba City and Sacred Peaks, and then now at Winslow are all tribally run. And so that's where I can speak to my experience is providing care in this area. And so the way things have typically worked is when there's not a service that's available within a service unit, then they get referred out through what's called purchased and referred care. So for example, before there was a full-time neurologist here, if again, somebody could wait and get on the schedule to see the rotating neurologists, they would do so. But if it was a more urgent issue or something that maybe that they weren't the best referral source, then that would get sent through what's called purchased referred care to a non-IHS facility. And so that's good because it offers the availability of care to the patients that need it. But the downside when it's not close by is that travel can be very tough. For example, in this area where I work at Winslow, that would typically, depending on the service, either be travel to Flagstaff, which is about 60 miles, or down to Phoenix, which is about 260 miles. And so certainly those longer trips to see a specialist can be tough on the patient, depending on their medical issue. And certainly with some of the things that our patient population face, may be difficult because of just the travel costs and time away from work or family, things like that. And also sometimes in some of the more rural areas, just the roads can be washed out. And so if that happens on the day you have your appointment, you're not able to make it. And then you may be waiting several more months to reschedule it. So that's kind of how care works within IHS when services aren't available. And the good news that I've seen personally, again, in this area, is that there have been more neurologists coming to Navajo area. Again, when I first came here, I was the only full-time provider back in 2012. But since then, there have been two others that have joined me. There's Dr. Wade Harris now at Tuba City Regional Healthcare Center, and Dr. Garrett Riggs at Northern Navajo Medical Center. And so we are able to provide more care in the area now at IHS sites. It can still be tough, though. I can't speak for Dr. Harris, but I know Dr. Riggs has to be a bit selective with his patients. His wait list is several months long. Mine is also still several months long. And so there certainly are things as general neurologists we're not able to provide, and so patients still do need, for example, if they need specialist headache care, they would need to get referred to a non-IHS site through that purchase referred care process. Thank
you, Dr. Stitzer. I mean, from what Mr. Yazzie was talking about is, it's a real privilege to have to be patient over those roadblocks, right? And not all certainly not in this community, there are structural inequities that kind of keep folks from being able to be patient. We talk about this a lot in the general migraine community in terms of, having to wait so long to see a specialist or having to travel pretty far. That's only amplified here, right? So this is
Correct.
a good time to bring in Dr. Matheson, who I know has thought a lot about this. We connected before this webinar. As I mentioned earlier, your dad was a founding member of the Association of American Indian Physicians, and we're talking about IHS fulfillment, and it's more challenging than just a financial resource issue. It's also about pipelining, right? The next generation of doctors and the folks who are committed to serve. Can you talk a bit about the pipeline issue and how AAIP is really seeking to work on it?
Yes, and again, thank you for having me today. When Dad and the rest of them started the AAIP, the goal was to do two things: develop more Native American providers and take better care of Native American patients. And we still struggle today trying to get that pipeline open to develop more Native American providers. There was a study out a while back that showed out of the last 55,000 med school graduates, only 24 identified as Native American. So there's not a large number of Native American providers coming through the pipeline, and the pipeline gets choked down because of different barriers, whether it's access to scholarships, economics, even the belief that you can be a doctor or some kind of medical provider. One of the projects the AAIP started last year, and they were doing it in combination with Mayo, is writing children's books to show children that they can be medical providers. There's actually books being published through Mayo showing the kids that they can become a provider. We're looking at recruiting efforts through the different colleges, med schools, even down into high school. Access to scholarships, access to grants, education for people to understand what we're trying to accomplish so that we can widen out that pipeline and we can develop more Native American providers and put them back in the communities, because the vast majority of Native American providers all want to go back and they all want to give back and serve their communities. So if we can develop more of them by taking down the different barriers, whether it's access, economics, education, these people all want to go back and they all want to serve their communities. And that would expand the access to healthcare for Native populations exponentially.
And that's our theme, which is, increasing access by breaking down barriers here. And so, I want to go back to something really quickly that Mr. Yazzie said about, the roadblocks and the waiting and everything that's placed as a barrier in front of a patient. Can anyone on the panel kind of talk a bit more, maybe Dr. Matheson too, about what it means for this community in particular? We hear about it in other communities of color, but for this community, I think before we hopped on together, Mr. Yazzie was talking about just how remote the area is and where he lives. And if you don't have reliable transportation, for example, how often is that a barrier? And how maybe Dr. Matheson, you could talk about how telemedicine might be a unique option that I think folks can tap into as long as there's perhaps the infrastructure there to support it.
I've worked predominantly in the upper Midwest, North Dakota, South Dakota, Montana, and Wyoming, and it is a long way to anywhere. They don't measure distance here in miles. They measure distance in how many hours it takes you to get there. We also don't have large population centers. Sioux Falls is one of the biggest populations at only 200,000 people. There's only 6 DRG hospitals in all of North Dakota, and there's 36 critical access. So there's no big population centers. There's no big hospitals. There's only 37 hospitals total in all of Wyoming, and 2 escalators, by the way. So to get people to where they need to be is very difficult. You got time travel, you got weather. We've just had a couple blizzards up here. Roads got closed. Do people have access to a vehicle? Can somebody drive them? A family member even take time off to help transport them. So all of those barriers exist, whether it's down, in the Southwest or up here in the upper Midwest. And telemedicine has grown exponentially. COVID sort of forced its growth, but it was starting to grow even beforehand. The company that I'm director of had bid a contract to do telehealth for 9 centers in Montana to provide a wide range of healthcare. And we're going to see, as technology develops, telehealthcare is going to become a huge player in the access to care. There's a couple places in Minnesota or Wisconsin right now that 90% of their clinic visits are telemedicine because people can get on a computer, but they can't get in a car and get to the clinic. So up to 90% of their visits are televisits. And that is going to be a way to get access to the specialists and subspecialists that hasn't existed before, because as computers and cell phones develop, that telemedicine thing is grown and is really good at getting people where they need to be.
That's helpful. And we talk a lot in the community about the importance of also having that ability, or not foreclosing the opportunity for folks to see their provider in person too, because for migraine patients where it's not a measure of high cholesterol or a blood test, it's really the relationship between the doctor and the patient that develops. I think we heard Mr. Yazzie talking about the consistency part, right, and how important it is that you just see a familiar face, and even if it's not someone that someone you've met more than once, and someone who you don't feel like you have to hit reset with and start all over. And that kind of goes to my next question. And before I start with the panel, I want to remind folks, if they have questions, additional questions for the panel, please feel free to put those in the chat box. We'll get to them if we have time. I'm sure we'll have a few minutes. But I guess it's the question of cultural competency, which a lot of folks are talking about right now. But, seeing someone who looks like you in terms of trusting your provider and care and treatment, Mr. Yazzie, could you talk about what it means from a patient perspective to know that perhaps there is a generation of providers who are coming from your own community to treat and serve this patient population, what it would mean to you, and the importance of sort of how that would increase the trust between you and your doctor? Is that important in this community?
Let me go ahead and go back to the remoteness and the importance of IHS providing services. The remoteness, yes, it is an issue, but right now, today, we kind of have improved the area where there's transportation upgrade, which we have what we call a CHR program, which is the Community Health Representative. And the Community Health Representative is the one that goes out to communities and they kind of assist the elderly and the handicapped and also children. And based on their health issues, she's able to refer them. And we have also what we call a non-emergency transport, where all these people, they have transport services that they transport them out to their appointments outside the reservation, and sometimes also within the reservation. So transportation is has improved a little bit, and now that the transportation has improved a little bit, but yet we still have those issues within IHS to where these resources are not available to us immediately. And sometimes it takes several appointments before we get to where we need to get seen and treated for what we were dealing with. So it's not just basically headaches, but in this case, that's what we're talking about. So that's kind of where it's at in the processes of IHS. So I would say that our people, our children, our new generation, we don't see, I don't see any doctors in IHS that are Navajo or physicians at that level. So basically what we're dealing with is our community members and our children have come back to IHS, but only as assistants to doctors. So that's kind of how it is right now. So I hope that answers your question.
Yeah, and I think that it goes back to the point of consistency. Dr. Stitzer, do you have a comment?
Oh, yeah, actually, a couple of comments, if that's all right.
Sure.
As far as to what Mr. Yazzie had just said, I did just want to put out there that actually I'm very honored to work with a Navajo physician, Dr. Michelle Tom. And so she's been here full time for a few years. And so it's great that she's here on our staff. And then beyond that, actually, the current chief medical officer that just stepped into the role earlier this year, or I guess last year, is also from the Navajo Nation, Dr. Loder Christensen. So there definitely are, again, at least speaking to my experience in the Navajo area, some Navajo providers. I know there are a few others. I'm not familiar with every single doctor at every single site, but I know there are some other Navajo providers within this area as well. So it is good to see that. And then also going back to the question of kind of difficulties with access to care, just to briefly kind of discuss some of the ways that I deal with that in my practice. Number one, Dr. Matheson is absolutely right that telemedicine has been a big help during the COVID pandemic. Being able to use that, being able to see people that way has actually, improved the ability for my patients to get to the clinic. The amount of patients that are showing up for their appointments actually increased with the use of telemedicine, because it gets rid of that transportation roadblock that all the different difficulties we've talked about that surround that. And then on the flip side, when I am seeing people in clinic, I try to approach it as providing anything and everything that they could possibly need while they're here, to the limits of what's available. And so, I'm lucky in that personally, where I trained in residency at Jefferson, there may be some of the people in the audience here, Dr. Silverstein, Marmura, Nahas, and Young, that they give a very strong foundation with headache care. And so, when I do see a patient, Mr. Yazzie thankfully was not doing extremely terribly when he came in. But when I do have a patient in that situation, if they need, onabotulinum toxin A injections or nerve blocks or infusion treatments, or we even have a couple of ETNS devices that we can loan out to patients for use. So when we have those kinds of needs, I try to address them while the patient's here versus having to say, oh, you have to come back another time, or same thing if they're late, we try to rearrange the schedule to make things fit. So it definitely does take some accommodation, and that's where with what we're talking about with the potential for headache centers of excellence, having all of those things there consistently in a location providing both in-person care and telehealth care with experts, being accessible to large areas of IHS, would be such an amazing resource. It would definitely go a far way towards addressing this problem.
And if I can say, Dr. Stitzer, without embarrassing you, you're sort of the gold standard or the one-man pilot program for a lot of this in terms of seriously understanding what treatments are available to patients. I mean, I think that for many migraine patients, the last 25 years have been sort of a desert where you had one or two options, and the inability for providers to adequately treat this disease. And of course, that has something to do with pipelining of clinicians. Why are you going into a medical field where you feel like you can't adequately treat folks? We're now in an era where there are all sorts of new things that can treat migraine patients, whether it's devices or whether it's neurotoxins, as you mentioned, all sorts of new therapies. But the question is, do folks know about them? And do they feel like they could access them? Because I know for non-native communities, a lot of the times if folks end up in the ER, you are dealing with providers who may prescribe an opioid or some other sort of pain relieving measure that's not optimal for their care and treatment and managing their disease. So would you say from your estimation that the community is aware? And I think going towards this idea of a National Center for Excellence, obviously you would have more folks who would understand the tools in the toolbox. Is that kind of a fair statement?
Yeah, I mean, I can say in my experience of the patients that I get referred to and see the care that they've gotten previously, certainly for abortive therapies, I think there's a fairly good awareness of the various options out there. I mean, we do unfortunately still see people coming from urgent cares or ERs at times just being treated with opioids, as a sort of a transient patch therapy. But we do have a GEPANT that's available through the pharmacies, the national pharmacy. We do have a lot of the other various supportive therapies, and it does seem like a fair amount of the general providers and emergency care providers are familiar with and utilizing those. It gets a little trickier, certainly, with patients that have chronic headache pain and need a preventive therapy or need a combination of preventive and supportive therapies. I think that's where it's not fair to expect the general provider or certainly the emergency or urgent care provider to have a lot of familiarity or facility with those kinds of therapies. And so that's where having easy, reliable access to a neurologist would help address those patients that are suffering the most.
Certainly. And I just want to acknowledge one of our HMPF is a stakeholder coalition, but one of our members, the Association of Migraine Disorders, has been providing for free general provider toolkits in Native communities. We'll include a link to those on the site that I think have just been very helpful for folks who, like you said, may not be steeped in what's new and up to date and helpful for patients. So we are going to hear from Dr. Shapiro in a few minutes, specifically about the Centers for Excellence, but to tease that, we would like to talk to, Dr. Matheson perhaps, and Mr. Yazzie about sort of what it would mean for you if there was a central hub like that, if there was a place where you could go and you'd know that someone there would be similar to Dr. Stitzer, who would be up to date and understand your disease and acknowledge the different options for managing it. I'll start with you, Mr. Yazzie. What would it mean to you to have a designated center of excellence in headache for this community that was really tailored to your needs?
Well, I guess IHS is presumed to be the jack of all trades, and with other ailments in different communities, such as larger communities where they have doctors' offices, like they would have separate dentists and separate neurology, separate for the knees and neck and all these different parts of the body where they specialize in that area. They have different offices. So, but IHS is a whole big one place, one shop, one-stop shop. But I think that is the reason why that they have so much going on to where they can't concentrate really on one person. So they have to either refer them out or try to treat them there for that particular issue. So just because there's really some of these doctors that don't specialize in one area, when you come to a doctor for that particular reason, then they can't help you, so they have to refer you out. So it would probably be uh, convenient, I guess, or effective with to treat people uh, if they have people that specialize in certain ailments to have their own offices that way. So I would say that that's probably one of the best ways to deal with it. So so that's where I'm coming from right now is for some of these doctors to move in, not necessarily to move into IHS, but maybe to have a separate office outside the IHS, and that would be more convenient. So, and as far as the doctors, I'm not sure, and I have not seen our natives be physicians or the ones that specialize in a particular issues with the people. So that's the only thing I'm not aware of. I guess Dr. Stitzer knows some of our Navajo physicians down in Winslow. So I haven't seen one in Chinle or Pinon, and that's kind of where I'm coming from. So that's my comment on that.
So you heard from Mr. Yazzie about having that hub would make things easier. You know, I think when Dr. Matheson, you and I connected, your first thing out of the gate was, look, the old approach, the same old approach isn't working. We do need to look for different solutions, different pilots, things that we could, you know, do that would be different and would perhaps help folks. So do you have any other comments that you'd like to add, Dr. Matheson, about what a Center for Excellence would mean for the community?
I do a lot of work as an emergency room doc, and I do some surgery as well, but especially as an emergency room doc, and it goes back to the technology thing. I would love to be able to have a center for excellence where I could just get on a computer, access their website or their system, read about what they recommend, talk to somebody through the computer, and it would make the start of somebody's care much better. You could get it, you know, you have these people that just overflow into the ER because they have no other access. You could get on their website, talk to somebody on the computer, start that patient's care, because we all know there's going to be a delay in getting them personal access, but we could use that Center for Excellence to start the change early, and it would already be in process by the time they actually physically got to see the specialist. And that would be a huge advantage to these people in their care.
Mm-hmm. I think we just have another minute before I turn it over to Dr. Shapiro, who's going to provide more details about the Center for Excellence. But I had one question come in from the audience that I wanted to ask because I think it's important. We talk about stigma a lot in this community. And last year, we did our session on first responders and veterans, and in particular, the warrior effect. And, you know, migraine in many cases is viewed as a woman's disease. You know, in the general population, it's 75% women. And so it's interesting that men, veterans, and Native Americans are perhaps experiencing a higher level of stigma. Do you find that to be true? And do you have any thoughts about how we could help break that down? I think maybe the answer is perhaps more sessions like this where we talk about it and we normalize it and we address it. But do folks have thoughts about that? Dr. Stitzer?
I mean, I don't know that I would say I've seen it stigmatized here, again, with my patient base. You know, I think we have data, and I don't have the numbers in front of me to be able to say if it's true, again, with my patients. But overall, you know, Native American men do have a higher rate of migraine and other severe headaches than the general population by I think about 50%. So that ratio isn't maybe quite there overall in the community. Again, I don't know within Navajo area. I don't have those numbers. So I mean, at least with my bias of seeing the person if they've already had the headaches for a while and have already seen a PCP or an ER urgent care doctor and have been referred to my clinic, at that point, that everyone's on the same page that they have severe headaches and need extra help. And I haven't personally at least seen any patients embarrassed about that or feeling stigmatized about that in the visits. I know we had kind of talked previously about how people sometimes come in with the view of, oh, this is just a headache, or maybe that stigma of feeling like they don't need the care, or there isn't care beyond just kind of the over-the-counter Tylenol and NSAID pain relievers because it's just a headache. And so being able to educate people and make them aware and understand their own disease process better, to know that this is something that we have various treatment options for that are dedicated to improving how you feel and getting this chronic condition under control. That part of it, yeah. I see, but I haven't seen too much as far as stigma by gender.
That's good to hear. And so all of these answers are a great segue to our final speaker, who is Dr. Robert Shapiro. He is founder of the Alliance for Headache Disorders Advocacy. He's going to talk about the great potential of an IHS Headache Centers of Excellence and sort of how it would impact patient access. So Dr. Shapiro.
Thanks so much, Lindsay, and thanks very much to Chairwoman Ledger-Fernandez, Ranking Member Young, and Mr. Yazzie and Drs. Matheson and Stitzer for casting a very strong spotlight on this really important issue, which has really gotten very little attention and I think deserves much, much more attention. So as was mentioned previously, this is a big problem specifically for the Alaskan Native American Indian community. Migraine is the second leading cause of global disability, and it tends to be more prevalent among women. So it's the leading cause of global disability among women under age 50. And for reasons that are just not clear, it's extraordinarily higher in AIAN communities. So if I could have the first slide, please. So in fact, 39% higher than the average across the United States. This translates to about 22% of AIAN community members, which within the IHS means over 500,000 community members are experiencing migraine or severe headaches this year. This actually is a problem not just across adults, but the data from other studies indicates that it's a problem for children and for adolescents. And for reasons, again, that are not clear, it principally is a difference in increase in prevalence among men. Can I have the next slide, please? And possibly a clue as to why that might be true is that the incidence of mild traumatic brain injury or concussion is twice the incidence across the baseline US population within AIAN community. So Mr. Yazzie's testimony of his experience is a potential clue as to one of the reasons why this is a more prevalent problem in this community, that is a concussion or traumatic brain injury. And the resources that are available within the IHS to help manage these problems is not adequate. If I could have the next slide, please. So Dr. Stitzer mentioned the 4 neurologists within the Phoenix and Navajo service areas, which constitutes about 500,000 people. So it's about 1 neurologist for every 125,000 people covered by the IHS. The number of neurologists across the rest of the United States within IHS isn't clear. So that may be a baseline. And that baseline means that there are 5 times more neurologists, 5 times better access to neurologists for Americans who are outside of IHS compared to those who are receiving care within IHS. And I very much appreciate Dr. Stitzer's expertise in this area. There are specific certifications for demonstrating that expertise in headache medicine, and there are no doctors within IHS that currently have received that specific certification. And as was noted specifically by Dr. Matheson, the number of neurologists who would be able to provide care who are AIAN community members is about a third of what you'd expect if it was parity across the population. So 1.7% of the United States citizens self-identify as AIAN, and only 0.5% of US neurologists do. So there are these vast disparities which need to be addressed for a community that is really the most impacted and affected by these disorders, which at baseline are among the most disabling that we know of. So there is a remedy. There's a remedy to begin to address this. And this is what we're urging in our over 265 congressional meetings today. Have the next slide, please. And that remedy is to follow the lead of what has been achieved within the Veterans Health Administration to create headache disorder centers of excellence, and do this within the IHS. So these would be regional and local centers, which would provide a variety of important services. So direct patient care, people being cared for in person, consultation, as Dr. Matheson described, an incident where it would be great if an emergency physician was able to provide expertise within headache centers of excellence to provide direct care in that setting, and telehealth. As Mr. Yazzie had pointed out, the remoteness, the difficulty of getting to clinic, this is an opportunity to be able to reach people where they are. And it really is accentuated for communities that live on remote reservations or rural communities, but it's also a problem for people who live in urban areas but don't have the wherewithal to be able to get to clinics. Education is a critical piece, both direct patient education, but in particular primary care providers. So 80% of outpatient visits in the United States for migraine are with primary care, not with a neurologist or with another specialist, particularly a subspecialist, such as in headache medicine. And we need to be able to ensure that the care that is provided as the first steps by primary care is aligned with what we know is the best care and the standards of care. And these centers of excellence will be able to provide that for IHS primary care providers. And finally, these centers could be an opportunity to provide fellowship training for new doctors who would be developing expertise in this particular specialty of headache medicine. Finally, it's critical that there be research performed in these centers because the goal is to improve care that's centered on the population. We're learning from the VA headache centers that there are differences between veterans who have these disorders and people in the civilian population. And we should expect that would be true as well within the AIAN community. There are cultural differences, there are needs that we need to be attending to and sensitive to that would improve the health outcomes, we hope. And each center would have doctors, nurse practitioners, psychologists, research coordinator, whatever ends up being appropriate to that particular community and center. Next slide, please. So the goal is to establish a system of IHS headache centers of excellence. And initially, it would be to set up 6 of these centers. That probably won't be the ultimate number that will be needed, but as a demonstration project about how best to do this, 6 centers spanning the 12 IHS service areas. Locations would be presumably at the discretion of the Health and Human Services Secretary to ensure that there's equitable access across these different constituencies within IHS, federal, tribal, urban, but under consultation with AI and AN, stakeholders to ensure that the sites are appropriately positioned and located so they provide the best and most equitable care. And again, to emphasize Dr. Matheson's point, the need is to be able to train and hire tribal providers and staff to ensure that the care is AIAN-centered care. We've received stakeholder endorsements from the Association of American Indian Physicians. Dr. Matheson is the treasurer of that organization, as well as the National Council of Urban Indian Health. And we believe that the cost of this is, at least within federal budgetary terms, quite modest, which would be $5 million per year. And we want the appropriations in fiscal year 2023 to be the first year of funding for that. That's our goal. This cost estimate is based upon what the costs have come in for the VA headache centers of excellence per site. And strongly we urge that whatever appropriations are to supplement, not supplant existing or planned funding for IHS. The last thing we want to do is to point out a health need, a major health problem, and provide resources there, and then deprive another critical health need, which was receiving resources at that expense. So we're eager for this to happen. We welcome the partnership of Chairwoman Ledger Fernandez and Ranking Member Young. We were very encouraged by those remarks, and we're hopeful that this is the year that this can make a change for this important community, which has insufficiently received resources, and the U.S. as a population, that we live up to our obligations to provide the appropriate care that we have a legal obligation to provide, as well as an ethical obligation to provide to the AIAN community. And thank you very much.
That wraps up our session today. I want to thank everyone for joining. I also want to give a special thanks to Dr. Shapiro and AHDA. They have worked tirelessly through modeling this idea at the VA, and we know it would be successful potentially at IHS. I also want to sincerely thank our congressional speakers, as well as our panel members today. To say that this is an important and timely conversation is an understatement. I also want to sincerely thank the Headache on the Hill advocates who will be doing the actual work today to help more migraine and headache disorders patients in Native communities. We appreciate you and appreciate all of the work that you're doing to move the needle for patients. Thank you all, and we will see you next year.